So our population, we had 64 patients with MS and 76 with what we would consider Alzheimer's disease or healthy controls. Um, and then when we broke down our patients, the people who were cognitively normal with MS was 33 compared to the healthy controls, which is 32. In the mild cognitive impairment group, the MS patients were, we had 17, and then in the mild cognitive impairment Alzheimer's group, there was 26. With our major neurocognitive disorder, our MS patients were only 14 compared to 18 with the major neurocognitive disorder who had Alzheimer's disease. So the discrepancy we saw between the mild cognitive impairment may just be due to the numbers that we had in both groups. So certainly we want to validate and look at that population a little more closely. While we are aware of our patients' cognitive trouble, I don't know that we do a prospective study on everybody with MS and look at their cognitive profile. So there is always a referral bias. They're coming to us because they think they have a memory problem. And we always know that people's assessment of their own memory difficulties is not quite what we truly see. So people always think they're having problems when they're okay, and then people who truly have problems think they're doing fine. So there's always a referral bias that we want to look at. There's a single center bias, and because we are certainly interested in cognitive problems and aging, we're certainly looking for those groups and kind of pulling out those differences. There's also just differences in the diagnosis, right? So people who are diagnosed with MS and are treated one way, they're not treated the same people who come in with Alzheimer's, right? They come to see different centers, they come to see different people, which means that the tests aren't always the same. So while the same battery was not given to our MS patients and our Alzheimer's disease patients, the skills that are being tested are similar enough. Well, what I think is interesting is for MS, there's a lot of treatment and there's a lot of intervention. And Alzheimer's, they're getting there. But one of the biggest difficulties in Alzheimer's disease is when do you start treatment, right? And if you treat Alzheimer's disease once they start having symptoms, is it too late in the pathology of the disease? And yet treating someone who doesn't have any symptoms feels weird too, unless you actually know, unless you have proof that it actually does something, like a really great preventative, meaning that if you take this when you're feeling okay, we can certainly prevent, dementia when you're older. And we don't actually know that. With MS, because the disease happens when you're so much younger, right, in your 20s and 30s, we can have a biomarker that allows us to treat early. And then as patients get older, we can kind of continue to follow them. So from an inflammatory standpoint, we understand the role of treatment early to change outcomes when you're older. But if we look at what's actually happening, both are neurodegenerative conditions, right? Both have, the microglia have a role in both pathophysiologies, and while one is cleaning up amyloid, the other one's dealing with the inflammation from demyelination. We might be able to learn more from studying these two diseases and comparing them that will then lead to maybe how we think about treatment and crossover in certain therapies that may teach us how to better treat Alzheimer's, and yet our studies for Alzheimer's might teach us how to better treat neurodegenerative processes that are happening in MS. So I think looking at that is always critical for us as scientists. From a really practical standpoint, all of our patients are asking that question, right? Like I said, the most common question I get in my clinic from my older patients who start having memory trouble is this Alzheimer's? How do you know it's MS? How do you know it's Alzheimer's? And the answer is, I don't actually. Let's study this and let's try to get those questions for you, because our biases, our beliefs was that if you had MS, you have a certain cognitive profile, and you have Alzheimer's, you have a different cognitive profile. And our study shows that that's actually not true. There's a lot more overlap. It is a lot more difficult to compare patients with MS versus just AD just based on their neurocognitive profile. And that to us should change how we look at our patients. It's like, so that it might be harder to say, is your problems just from an MS? Is your problems from AD? Is there overlap or not? And I think our study really highlights that we need to better look at these questions.